Well, thank you guys for coming to this didactic session. This is the annual What You Need to Know About Social Needs, the top social emergency medicine papers of the previous year. I'm Jahan Fahimi. I'm from UCSF, and I'm joined by my esteemed colleagues, E Wang from Stanford and Harrison Alter from Highland. And before we jump in, I just want to give a quick shout out for the Social Emergency Medicine Population Health Interest Group meeting tomorrow morning at 8 a.m. It's an interest group within SAEM that is sort of the sponsor of this didactic session, and we're hoping that as we go forward, we'll pick up some additional members. So if you're not already a member, please come and join us. So this is the third time, I think, that we're doing this, the third year in a row that we get to do this topic, and we're very excited to do it again. We kind of struggle every year with what our approach to selection of papers should be. When we first started this, it wasn't quite as hard. There wasn't that many high-quality articles that sort of really fit the bill of what we thought of social emergency medicine. And then in the last 3 years, that has just exploded. And so now we struggle with how do you choose the right articles for presentation in this forum. So we kind of have a method to the madness. The first is that we try and choose large concepts, big concepts and categories within social EM. We want to make sure that some of the topics of the papers are timely to where we are in emergency care. We'd like to have a representation of various research methodologies. And then we do some sort of systematic searches. We search for topics in emergency care. And then we look through reference lists and authors to see if we can identify additional references. Harrison and I have done a number of meta-analyses and systematic reviews, and we try and apply a little bit of that methodology to this. That being said, going forward, if you guys ever come across a study or you publish a paper that you think is worthwhile for this forum, please email us and put it on our radar. This is kind of the systematic way that we've approached this. This is meant to be a joke. So with that, we're going to jump right in.
We have so many microphones. Hopefully one works. Basically, I'm really excited to present this first paper because it's done by a former medical student of mine who is now a fellow in pediatric emergency medicine. And she did this project as a pediatric resident in Boston. And we all know that homelessness is a very complex and important public health problem that runs into emergency medicine care often. And homelessness has a lot of negative health outcomes. And for children, specifically asthma, obesity, developmental delays, mental health issues, and homeless children have been found, like adults, to have more ED visits. There have been previous studies looking at ED use among homeless populations, but none really focused on children, and none really focused on children requiring shelter explicitly, as opposed to medical services. So what I really liked about this study is that they used observations in their ED. In other words, they said, hey, there are more kids coming in homeless. I wonder what is causing this. They sought to quantify this to then advise policy. So there was a regulatory change in 2012 in Boston housing policy that required that if children and families were to be eligible for shelter, they had to have experienced domestic violence, a natural disaster, no-fault eviction, or they had to prove that they had stayed somewhere not meant for human habitation. And what they realized, the practitioners realized, was that over time, homeless families went to the ED not just to be safe, but also to have discharge paperwork to then go to a shelter and say, hey, we need shelter. So basically what they did was a retrospective analysis of 1 year before and 1 year after this policy was in place. And they basically looked at patients who came in with a chief complaint of homelessness, or they had a billing diagnosis of homelessness, or they had a chief complaint of social need and a secondary billing diagnosis of homelessness. They actually excluded all homeless patients who came for medical needs because they really wanted to understand the ED as used for shelter. What's important about this population is that there were 1,078 visits by about 900 children and young adults. One half were younger than 5 years of age. About 43% were Hispanic and another 43% were Black. And 81% were on Medicaid. So you can see in this table the comparison of the population visits before and after the policy changes. Before, the median number of visits was about 3, and afterwards 15. And then they summarize it much better in the paper, I think, than in this table. But the visits led overall to 8,658 hours of emergency department occupancy, of which 212, 2.4% were before the policy, which means that 97% were after the policy took place. Total hospital charges were $578,000, of which 3.3% were before the policy change, and the net payment over the study period was $214,000, with 97% paid by Medicaid. This is a really nice quote that Harrison found. There's an ongoing tension in the care of vulnerable people between medicalizing a social problem and recognizing the risk within the socioeconomic gradient in health. So this policy seems to feed rather than resolve this tension. But what I could imagine is with this quantification of the results of this policy, the hospital can go to the Boston Public Housing Authority and try to implement change that will reduce the burden on the healthcare system.
This is a great study because it does really take advantage of like a natural experiment and really draws a direct line from my perspective from policy to what we see in the emergency department, which we all know is true, but more research on that I think makes the case for us and what we do every day. So our next study is this study that was published in the Annals of Emergency Medicine by Liz Samuels. Couldn't be here because she had surgery. But this was a quality framework for ED treatment of opioid use disorder. This is a little bit of a different type of study than what we normally present up here. The author's overall sort of question was, are there best practices to guide ED improvement efforts to reduce opioid-related morbidity and mortality? And in order to sort of develop a framework for these best practices, they engaged multiple stakeholders from an NIH institute, from ACEP, from CMS, as well as experts in the field. And they said, let's come up with some sort of quality improvement framework that can guide policy, research, and clinical work for emergency departments across the country. And what's really wonderful about this is it's a very rigorously and well done framework that they've laid out here, but that this model can be used as a quality measurement framework for really any ED-based improvement initiative that's trying to address social determinants of health or quality of care, clinical quality of care. And in the paper, they actually do a really nice job of drawing analogies to care for acute MI, for stroke, for sepsis, and how something like addressing the opioid epidemic from the lens of the emergency department can be seen in that same exact framework and should be seen in that same exact framework. And I think the key is in the article itself, there is a table 2. And so if you're specifically interested in how can I address opioid use disorder in my ED, or what should my research policies be, or what should I be advocating for within my health system, within my local government, this is the table to go to, because this is sort of the expert consensus. And this is kind of a summary of what that table does. It basically says we've identified kind of 3 different opioid use disorder domains. We want to be in the forefront of primary prevention. We want to be engaging around harm reduction techniques to sort of reduce the morbidity associated with use. And then we want to be engaged in actual treatment of opioid use disorders. And then they say, okay, what should we be measuring? What should our quality framework be looking at? There are structural measures, process measures, and then outcome measures. And again, there's analogies for all sorts of other conditions in this framework. And so I won't go through every single cell because that would take a very long time. There's multiple points within each one of these cells. But for example, if you're interested in what are some of the structural measures that I should be putting in place with respect to, say, primary prevention, it might be something like the prescription drug monitoring program and EMR integration. From a harm reduction standpoint, and let's say you're looking at process measures, what proportion of patients are discharged home with naloxone, for example? And then from a treatment standpoint, you may want to look at things like in-hospital mortality or out-of-hospital mortality, depending on if you're interested in the ED lens or a population lens. And so again, I really urge everyone to take a look at this table 2, and then they've then taken the findings here and kind of integrated into what a learning health system how it might use this to engage with policymakers, engage with the health system, and to engage with quality improvement departments in medical centers. The other thing that I'll give them huge credit for is that this framework, I mean, you're taking something like that we're passionate about in the emergency department, like opioid use disorder, and they're applying it, their approach uses the language of departments of quality and improvement specialists and implementation scientists. And now you can sort of draw on additional resources as opposed to sort of going at it alone in emergency departments. I think this makes it broadly applicable to other stakeholders within our care systems. So the next study is me as well. This is a study that Harrison was one of the authors on, a study that looked at alcohol use and intimate partner violence severity in U.S. Among ethnic groups that present to an urban emergency department, my alma mater, Highland. And the question was, what's the sort of the distribution of sociodemographic factors among ED patients experiencing intimate partner violence? And the novelty of this study, the innovation here, is that we know that emergency department patients report high levels of intimate partner violence. We also know that there are racial and ethnic disparities in reported IPV rates. But this is really the first study that looks at race and ethnicity in emergency departments and looking to see what the distribution of IPV there is. I give the authors tremendous credit because they used a really, really extensive survey, and they deployed it in over 1,000 patients over just a few months. And embedded within the survey were really wonderful tools, validated surveys and instruments to assess things like intimate partner violence, alcohol use, drug use, mental health, neighborhood effects, adverse childhood events. And so it's a really well done and methodologically rigorous analysis. And as I'm reading it, I can absolutely see Harrison sitting in the room saying, well, we need a metric on neighborhood depravity and all these things. So they did a really, really wonderful job of measuring socioeconomic factors, both sort of upstream and downstream effects for drivers of intimate partner violence. So I think the most important, most striking thing here is that the incidence of IPV in the previous 1 year was 23% among these ED patients, which is huge. And this could be either as a perpetrator or as a victim. But that's a striking number, and that fits squarely right in the middle of what we kind of knew already. But it's an important reminder. Intimate partner violence is associated with sort of being a younger age, alcohol use disorder, PTSD, other mental health conditions as well, and then adverse childhood events, which I think are important things to recognize. And the reason we decided to put this in here is, from a healthcare disparities standpoint and from a race standpoint, the finding was that black subjects are more likely to be exposed to intimate partner violence as compared to other races. Up to 34% of the black subjects reported IPV in the past year. But what was really neat is if you look at the univariate and the multivariate analyses and point estimates for this, you can see that a substantial portion of the impact of the association between being black and reporting IPV can be actually explained by sort of upstream socioeconomic factors. And Harrison put it really well last night. It's not the color of someone's skin that results in them being assaulted by their partner. It is the experience of their race and the world in which they live that may be the real driver. And I suspect that if you could, really go in and measure with even higher fidelity some of the impacts of living in this community and the disparities that populations experience, you would probably be able to explain away even more of this race finding.
Is this me? Yeah. Oh, goody. So this is a paper from BMJ Open that gets a little bit of a start on what I think is going to be an increasingly important social determinant of health, and that is criminal justice contact. It's actually very poorly studied, but in typical form, Renee Shaw is ahead of the curve, and so she and her group in California sought to answer this question. Very simple question. It's a great way to start a field. How do ED patients with criminal justice contact compare to other ED users? And so what they did is they took the OSHPOD data set, which is the California contributor to the HCUP data set that many of our health services researchers use. It's comprehensive discharge data set from California EDs and inpatient stays. And they looked to see whether the patient arrived by criminal justice conduct or was discharged to law enforcement. And they counted that as a visit attributable to criminal justice contact. And then they also looked at visit frequency and tried to define frequent users as well to see whether the criminal justice contact was a definer in that realm, and for that they defined frequent use as greater than 4 visits per year. So this is their sociodemographic slide, and what this slide demonstrates is that those of us who have been paying attention to mass incarceration would not be surprised at all that the patients with criminal justice contact were much more likely to be black. And the patients without criminal justice contact were much more likely to be Asian, and that they were sicker. The patients who arrived by law enforcement had a much higher admission rate to the hospital. This slide actually is the diagnoses associated with the visit in most cases, and you'll see that leading the pack in every respect is behavioral health and substance use disorder. So as Jahan has pointed out before, this really illustrates the fact that the emergency department and jail and prison systems have become the main providers for behavioral health services in the state of California. There are limitations to this study, but again, it's sort of a first pass. It's meant, I think, to introduce us to this notion, to alert us to the problem, and to sort of say ready, set, go to social EM investigators who are ready to study the relationship between law enforcement and emergency department use. So there's not a ton of data right now supporting the relationship or this notion of criminal justice contact as a social determinant, but we all know that there is a relationship, and now that we know their differential use, it throws it squarely into the camp of social drivers to ED care. This is me too. Okay. This paper is a kind of, and by the way, are there authors from this paper in this room? Yeah. So you could just come up and do this for me. There's no reason that I should be expected to be an expert on your paper, except that I'm just a huge, like I'm a fanboy. So this is a kind of a health services research tour de force. To do this paper, you not only have to understand how risk adjustment is done, but you have to have enough facility with the process to climb under the hood and check the timing belt. I mean, I guess cars don't have those anymore, but this is really high-level stuff in my mind, and I just am so admiring of the fact that they were able to take the top off the black box of risk adjustment. Now, just to back up for a second, risk adjustment for CMS quality benchmarks is a big deal. CMS can take points away. These are actual reimbursement points, so this is money. This isn't just some sort of abstract concept. So when benchmarks aren't met, they take money away from hospitals, and hospitals don't like that. So hospitals have figured out over time ways to promote at CMS the risk adjustment process, and that allows tertiary and quaternary hospitals who take care of super sick patients to not get penalized when their patients die more often, right? Because if we just looked at raw death rates, the hospitals taking care of sick patients would do really poorly. So we do risk adjustment. But safety net hospitals, which take care of patients at the bottom of the socioeconomic gradient, don't have any risk adjustment processes happening to defend us. I was going to say them, but it's really us. And the sociodemographic factors probably are just as important comorbidities of disease as any of the factors that are already entered into the risk adjustment process. They've just never tried it. So at the urging of the National Quality Forum, which is where a lot of these benchmarks come from, these investigators from Penn, in our presence, now I'm really feeling, they used statewide administrative claims data to explore the idea of adding sociodemographic features to the risk adjustment formula for in-hospital mortality. So they really just, race and ethnicity were in the data set, so those were easy. And then they looked at just a couple of poverty variables by estimating the rate of uninsurance and Medicaid insurance in the data sets, and then by looking at lowest quartile zip code poverty rates, so that you were ranked as being poor in this data set if you resided in the lowest quartile income zip code. And so this is kind of a complex slide, but what they found was that in their state, of 157 hospitals, with this new risk adjustment, three hospitals moved out of the bottom decile, where you get penalized, and 3 hospitals were moved into the bottom decile, where you get penalized. The 3 hospitals that moved out of the bottom decile took care of a much greater proportion of non-white patients, and took care of a much greater, 56 compared to 10% proportion of poor patients. So these are our safety net hospitals that were being penalized for essentially killing too many people by the CMS system, and now we know that they're just sicker, right? They're just sicker. And this is just a very first pass kind of broad brush attempt at risk adjustment for sociodemographic features. This is a cool slide that I don't know if I have time to actually describe, but this is, you look at the relative fatness of the bands as they move from the pre-adjustment side to the post-adjustment side, and you can see that after adjustment for sociodemographic factors, there's a nice fat band of hospitals leaving the bottom two deciles of failure to meet benchmarks. So this is a system that, when perfected, can really benefit and help keep alive safety net hospitals. And I don't know if you guys have any other comments about it.
Yeah, there's some additional papers at much higher level showing that basically found the same thing for BMI, pneumonia, and CHF. So there's a growing movement after these things.
Fantastic. Thank you.
Okay, so this is my favorite paper of the year, maybe of the decade. It is a single hospital, retrospective, observational study that will probably, if used correctly, could save the most lives and save a lot of money. And so it just shows what you can do with observational data. So scheduled 3 times a week dialysis is effective, evidence-based treatment for prolonging and improving quality of life for people with end-stage renal disease. The good thing is that there's nearly universal coverage by Medicaid for this procedure, but 40 out of 50 states deny this treatment to patients who are not eligible for federal assistance. So these are basically undocumented immigrants. So these patients, or these individuals, what they receive is emergency-only dialysis. So when their end-stage renal disease is so bad that they are hyperkalemic, they're acidotic, they are uremic, or they're volume overloaded, then they get dialyzed in the emergency department. Now, we know that dialysis saves lives, but this discrepancy in treatment persists because it's perceived to be more expensive to give scheduled dialysis to these immigrants. But there has been no robust data analysis, comparative effectiveness, looking at the cost of the scheduled and emergency versus emergency-only dialysis. So basically, in 2014, uninsured individuals with end-stage renal disease in Texas were eligible to purchase private insurance that would allow them to get scheduled dialysis. The only requirement was that these individuals were able to go to a dialysis center and be accepted there for their weekly treatments. Basically, what Parkland is where this study was done. It's among the 5 largest safety net hospitals in the United States, and they basically went through and looked at all of the patients that were eligible, about 189, I guess, and almost half were able to receive dialysis. And then what they did was they looked at these 2 groupings of patients, looking at survival as well as doing a difference in difference analysis to look at utilization of healthcare resources. And if you look at the patient population, those who were able to receive scheduled dialysis were slightly sicker than those who received emergency-only dialysis, which would only magnify the treatment effect. Then, if you look at the Kaplan-Meier survival curve, you can see that those who had emergency hemodialysis had a 17% one-year mortality, versus those who had scheduled hemodialysis who had a 3% one-year mortality, resulting in an absolute risk reduction of 14% and basically 7 patients with scheduled hemodialysis to save 1 life. This is one of several of their graphs showing the utilization of these patients who received either scheduled hemodialysis versus emergency hemodialysis. And basically there were 6 fewer ED visits per month, 1.5 fewer hospitalizations, 10 fewer hospital days per 6 months, and decreased costs of nearly $6,000 per month per patient. Okay, so what this shows is that we already know the medical standard of care saves lives. We've showed that it decreases utilization, and it shows that it decreases costs. And the fact that it affects one population shows a clear policy going forward. So, Harrison.
What's next?
Fire.
Fire. Oh, wait, did I shout fire at a crowded room? Yeah.
Yeah, so I think that the majority of patients, there are many reasons patients don't get dialysis when it is required, but this population had been restricted to never being able to receive scheduled dialysis. They always had to go on an emergency-only basis. And so that's what's so wonderful about this. We have a population, okay, and we know exactly what we can do with this population. We can give them scheduled dialysis. Now, they might not come, and that's a different issue. There might be other issues of access. But just based on this, I see no reason this cannot be extrapolated to other places. That's it.
I mean, I think my takeaway from this is a number needed to treat of 7 with a cost that is, it's a negative cost. I mean, it's a savings. So it's like if you implement this, you will save money and save lives. I mean, it's a no-brainer.
Well, that actually would be a great study, right? The social drivers to missed dialysis. And once we get to the bottom of that, then we might be able to address the social needs that are behind that pattern. Thank you for that. So moving forward, we're going to cover a really beautiful paper that my colleague Dr. Fahimi is on. And this paper continues our thread in this series over the years on the significance of place in social emergency medicine. 2 years ago, we had a paper by Doran and colleagues on changes in the pattern of homelessness resulting from Hurricane Sandy. Last year, we looked at the cost analysis of the regionalization of opioid use disorder and overdoses by Dr. Dworkis. And this year, this paper kind of digs one layer deeper to look at actual physiologic effects of climate-related natural catastrophes. So the question this paper answers is, in an era of climate change, how might geography impact cardiovascular, cerebrovascular, and actually respiratory also emergencies? I'm including this slide just because I like to say this. So in spatial epidemiology, this is called a heat map. This is actually a heat map. So this map, it's funny unless you live in one of the orange counties. Red counties. So this looks at the geographic concentration by fire basin of wildfires in the 2015 season. So what they were able to do is the Bay Area, the California Air Quality Management Service introduced a new sensor, right, that is able to detect smaller particles. So we've long been able to detect suspended particles that are asthma stimulants, right, that are inflammatory to the to lung tissue, but now they can get down to 0.2 microns. Is that? Yeah. Which cross the capillary membrane, enter the vascular space, and are then capable of inducing vascular endothelial damage. So we have a biologic now explanation for why exposure to wildfire smoke should, real-world wildfire smoke, not Game of Thrones, wildfire smoke, why that should induce cerebrovascular and cardiovascular outcomes. And then the respiratory outcomes would be related to the larger particles, I think. And so this is kind of, I think, the most important slide in, figure in the paper. It's a methodologically bulletproof paper, but what you see here, so we have the biologic hypothesis for why this occurs, and then what they're able to demonstrate is actually one of the key determinants of biologic plausibility is the dose-response curve. So you see the red dots, which are younger patients, which goes up to 64, which there's really little effect, which we would expect because they're at lower risk for bad outcomes from endothelial damage. But then older patients who aren't as lucky are the blue dots, and you can see a clear dose-response relationship to smoke exposure and subsequent cerebrovascular and cardiovascular events. Now, the respiratory events, they also demonstrate it's not quite as surprising a finding, but it's still important for us to know what's coming to our emergency departments as climate change overtakes us. So the wildfire seasons are getting longer and more severe, and we got to be ready, even if you don't live in fire country. Mental health.
Yeah.
I just want to say one thing also about the paper is that we know climate change affects health, but it's actually very difficult to quantify and qualify that effect. We also know that the climate change has a disproportionate effect on different populations, and the emergency department can serve as kind of a surveillance area for the patients who come in as a result of different acute climate change events like fires.
And I think the acute part is the key because in the study, the lag time is 0 to 5 days from the peak smoke exposure. So these are very immediate effects of wildfire smoke exposure. So this next study is study again with one of the authors being Renee Shaw. I feel like you can't do this forum without showcasing all of her work. And this study looked at the factors associated with ED use by patients with and without mental health diagnoses. And the question was, what factors are associated with higher ED use? And actually, you could have truncated the question there because this study really just looks at every ED visit in California in 2013 and looks forward and backward by a year to develop a model to sort of say what predicts repeated ED use. And the impetus for focusing on the mental health component in this study was really because under the ACA, there was the Medicaid expansion, and the Medicaid recipients that had mental health conditions were eligible for a broader set of benefits. And you could understand that if you want to better care manage these patients and develop complex pathways to address mental health issues, now you have a vehicle for which to do that. But these authors said, well, let's look to say, among non-elderly adults, what is the sort of burden of mental health, and how does that predict future ED use? Can the ED be a place where we might intervene? And so the results, as I said, they're looking at pretty much all important drivers of repeated ED use. Not just mental health. And so, if you want to just glean some additional inference from this, it's, payer, anything that's basically non-private payer predicts, subsequent ED use. as well as exposure to poverty, living in a poorer neighborhood. What's interesting is that the Medicare group has a really high association with subsequent ED utilization, and I think it's because these are non-elderly adults, and so you have to be disabled to be in this population, so this is a high-risk group of people. And if you want to look at some other factors, having previously been hospitalized and past frequent ED use are obviously really important drivers of whether you will use the emergency department and how much you will use it in the coming year. That's not surprising. If you have a primary mental health diagnosis, there's a 31% increase in the number of visits in the subsequent year that you will have. And then again, they showed this wonderful dose-response relationship. And so I think that this lays out a really clear explanation for what we know to be true. And then they sort of took it another step further and they said, well, let's look to see how mental health interacts with a whole host of other diseases. And it turns out having other medical conditions don't appreciably alter this relationship. The only interaction that was significant was that if there was mental health plus substance use or injury, you have further increase, like another 12% increase in subsequent ED use. And so I think the implication here is that we know that we're going to have these patients coming into our ED, that they are going to be frequent utilizers of the ED, and that now that we have in California a mechanism by which to provide benefits to some of these patients, we should hopefully be able to bend this curve and reduce this utilization and provide mental health care to patients where they actually need it, not necessarily in the ED.
So this elegant little study speaks to one of the more neglected social determinants of health, language proficiency. And basically it's known that limited English proficiency patients have poor health outcomes, and they have higher rates of ED recidivism. And frankly, under Title IV, the 1964 Civil Rights Act, they are entitled to meaningful language assistance. So this study took place in a public hospital in LA County with about greater than 60% non-English language speaking patients. The hospital does have 24/7 access to phone and video interpretation services, as well as a bilingual employee certification process, of which about 18% of their employees had obtained. And their objective was simply to characterize the unmet need for language assistance in their public ED. They wanted to look at the use of language assistance during the initial ED assessment, as well as looking at the unmet need for language concordant patient education materials and on discharge. So basically, they took another advantage of a natural experiment. Basically, they had implemented a new electronic health record in their department, and part of this electronic health record had a spot for the ED registration people to ask, number one, what is your language of preference, and number two, do you want an interpreter? And they would check the boxes. But unfortunately, the providers did not know that these boxes were checked, so they proceeded with their usual way of work. They obviously, so what they did was they waited about 6 months after the electronic health record was implemented, and they've looked at all patients, all comers, for 48 hours. They excluded critical patients or those who were altered and could not speak. And overall, there were 271 ED patient encounters. If you look at the left side, you can see that the mean age was about 41 years of age, and 79% were Hispanic or Latino. 134 patients would prefer their care in another language, and 110 of those requested an interpreter. And basically 93 of those, or about 12, 16% received the interpretation and 85% did not. If you look at the second side on the left, of the patients who were discharged, there were about 95, I believe, and 66, I can't see the screen from here, received written concordant discharge instructions. Now, it's interesting because there are pre-written discharge instructions in the language, and then there's also free text. So there were some entries written in free text, which the author surmised was probably used kind of Google Translate. And of those, about 75% had fairly bad language errors, not accents or anything like that, but large miscommunications. So basically, in a large public hospital, 53% of the patients referred a language other than English, and the unmet need for language assistance was 85%. Unmet need for language concordant instructions was 30%. In the discussion, the authors talk about, and we talked about, what could be the cause of this. The providers could have just not documented using an interpreter, but what's not documented has not been done and probably does not account for the vast unmet need. The authors surmise that probably family and friends are being used for interpretation, and it has been documented that that is fraught. And then it was also noticed that there was a reluctance, actually, for obtaining an interpreter, as if this would decrease the flow or the speed of care. And so this is important because there's such a glaring incongruity between the language needs of the patient and what is being provided. And the gap is widening over time, despite literature that shows the need for the contrary. And I guess there are new marching orders.
Good. Thanks. I think I have this one. Is this on? Yeah. So we only have a minute left, really, so I'm not going to spend a lot of time on this paper. But we want to try to include a qualitative methods paper every year. This is an excellent one, especially in light of yesterday's plenary talk. This basically gets to the fact that they used qualitative methods in suicidal patients or patients with an experience of suicide who are gun owners to try to refine what the right language is around the conversation for suicide prevention, for limitation of access to lethal means in depressed patients. And so they created this handy-dandy card for us on the basis of the results of their qualitative interviews. The themes they identified were there is an identity to being part of the gun culture. It's an important thing. You got to recognize it. You got to understand it and understand where your patients are coming from. There's a matter of trust. It's hard to build trust between the two cultures. It's a definite cultural divide unless you're a physician, an emergency physician who happens to consider yourself or identify as part of the firearm culture. Reinforcing that restriction of access to lethal means is voluntary and temporary was very important to the patients. Context was important. In other words, putting it in the context of keeping your pool safe for your kids, making sure your medications are child safe. We don't think twice about counseling on these things. Firearms are the same issue. There's a language issue. Don't use the term gun. They prefer the term firearm and weapon. So that's important for me to learn as someone who's not part of this culture. And the whole trying to steer the conversation for voluntary and temporary restriction of access to lethal means as not being part of background checking, because that's a separate and fraught issue. So I think that's all we got. We'll tweet out the reference list for the top 10. This is not a definitive thing, right? It's not, there's no magic here. If you have contributions to the list for next year, we'd love to hear them. And you have anything to add, Ewan, Jahan?
Thank you.
Tomorrow morning, 8 a.m., the Social EM and Population Health Interest Group. It's the room where it happens. And follow #SocialEM, and you'll get access to this reference list. Thanks so much, everybody.